Yeah.
Welcome to this month's edition of the ASGK Grand Rounds, the program that we have been going on for the last probably, I think, 1.5 years now. Close to 2 years, I think, isn't it, Pidambaran?
Yeah, it's not 1.5 years.
Yeah, 1.5 years. So today we have an interesting case of sarcopenia, as I understand, from this Avitis Institute. And the moderator for today's session is Dr. Abhishek Yadav from Lakeshore Hospital. Over to Dr. Abhishek. Please take over.
Good evening, one and all. At the outset, I would like to thank Dr. Pitambran and ISGK for giving me this opportunity. Today's case is being presented by Dr. Safina, who's a junior doctor, and she's being mentored by Dr. Raj Kamal, who's a senior consultant gastrointestinal surgery at the Avitis Hospital at Palakkad. Dr. Raj Kamal also happens to be a very dear colleague and an erstwhile student of mine, and he was a very bright student, I must say, if not one of the best students that we've had at Lakeshore. And he and Arvind were instead, they were quite instrumental in setting up the liver unit for us at Lakeshore, and for that, I think I'll always be indebted to them for. Dr. Rajkamal was always an excellent surgeon and excellent assistant also. And I'm not surprised that he's doing this high-end work at a distant place like Palakkad. So today's case is being presented by Dr. Safina, who's one of their bright junior doctors. And she's going to talk us through a case of locally advanced colon cancer, which required multi-visceral resection, and in a patient who was very frail and sarcopenic and also happened to have a liver disease. So Dr. Safina can now take over and take us through a case, unless Dr. Pitambran has something else to say.
No, let's Safina start.
Good evening, everyone. My name is Sapna Pawan. I'm working as a junior resident in the surgical gastroenterology department. Now, today I'm assigned to do a presentation regarding the topic multi-visceral resection in sarcopenia. Let me start my topic.
You can share the screen, Safina.
A 56-year-old male hailing from Mandai, Palakkad, he presented with complaints of pedal edema, decreased appetite, and weight loss. He was an alcoholic. He takes around 2 to 3 pegs per day, but stopped since 4 years. He was a smoker also. On general examination, he is moderately built and poorly nourished. He weighs around 63.4 kg. Pallor was present, bilateral pedal edema present. On examination, per abdomen shows abdominal wall edema. His investigations were as hemoglobin level was 6.5 gram per deciliter. Serum albumin is 1.2. USD abdomen shows features of chronic liver parenchymal disease with moderate ascites. Ureoscopy was done, which shows ulcerative growth, which is seen at the first part of duodenum. CECT abdomen was taken, which shows irregular circumferential enhancing mass involving distal ascending colon, hepatic flexure, and proximal transverse colon with obliterated fat planes with first, second, and third part of duodenum. Positive oral contrast is seen tracking through a fistulous communication from duodenum into hepatic flexure of colon, with suggestion of CA colon with malignant Colo duodenal fistula. Fat plane of mass with segment 4B of liver appear lodged with small contiguous area, increased enhancement in segment 4B of liver with suggestion of liver infiltration. Few round enlarged pericolonic and mesenteric lymph node. Fat plane of mass with fundus of gallbladder appear indistinct, moderate ascites, and mild bilateral pleural effusion. This is the AV of CECT abdomen. He was started on total parenteral nutrition as his nutritional level was very poor. High protein diet was given, injection and IV antibiotic, injection albumin, diuretics, injection vitamin K, incentive spirometers were also given. Patient developed allergic reaction while giving albumin infusion. Multiple brands were tried, but for all the brands, he developed reaction. Under steroid cover, albumin infusion is continued with strict vitals monitoring. On the day of surgery, his albumin level is 2.3. During admission, his HB level was 6.5. 1 pint PRBC and 4 pint FFP were given. After 2 weeks of admission, his hemoglobin level dropped to 4.1. So we have given 2 pint PRBC transfusion. 2 days prior to the surgery, he had one episode of hematemesis for which we have transfused him with 1 pint of PRBC. On the day of surgery, his HB level is 8.4. After getting clearance from cardiology and pulmonology side, patient was taken for surgery under high risk. He underwent en masse right hemicolectomy with distal gastrectomy, proximal duodenectomy with radical cholecystectomy, and wedge resection of the liver with gastrojejunectomy, feeding jejunostomy, and end ileostomy. Specimen shows large mass arising from hepatic flexure of colon infiltrating the duodenum, gallbladder, and liver. Specimen was sent for histopathology. The report shows us right hemicolectomy specimen shows growth in colon with features of adenocarcinoma, which is moderately differentiated. Tumor is infiltrating the submucosa, muscle coat, and peripolic fat with infiltration into the gastric and duodenal wall, liver, and gallbladder. Foci of lymphovascular invasion seen. Surgical margins are free of tumor. 0/2 perigastric lymph node and 5/39 pericolic lymph nodes show metastatic carcinoma with lymphovascular emboli and perinodal infiltration. 5/41 lymph nodes are positive. Omentum is free of tumor. Primary in the gallbladder, infiltrating the entire wall into adjacent organs cannot be excluded. During post-op period, patient was managed with supportive medication, breathing exercise, and feeding jejunostomy. Patient improved symptomatically and he is being discharged in home stable condition. He underwent adjuvant chemotherapy. Capox regimen was given. Injection of oxaliplatin 150 mg IV and TAP capecitabine 500 mg 202 are given. He underwent around total 6 cycles of adjuvant chemotherapy. During the second admission of chemotherapy, patient presented with complaints of left-sided lower abdominal pain. An examination per abdomen shows tenderness over left iliac fossa. CT was taken, which shows anterior to gastrojejunectomy anastomotic site, there is a loculated pocket of fluid collection with air abutting the anterior abdominal wall would represent the anastomotic leak with collection formation. Mild ascites also there. This is the CT film of Ureoscopy was done, which shows diffuse gastritis, post-gastrojejunectomy status, porous gastroparesis, or distal obstruction. Patient managed conservatively with antiemetics, PPIs, and other supportive measures. Collection ruptured spontaneously and was managed by daily dressing. Patient is discharged in stable condition. He was admitted for ileostomy closure, which is actually delayed due to COVID-19 pandemic after 1 year of his first surgery. USG abdomen shows post-op status. There is no focal lesion in the liver. There is no significant lymphadenopathy. CT abdomen was taken, which shows over-distended residual proximal stomach with no obvious abnormality at gastrojejunal anastomosis, pattern ileostomy, and there is no ascites. Ureoscopy shows gastritis and post-gastrojejunectomy. Colonoscopy was done, which showed diversion colitis. Patient underwent laparotomy, adhesiolysis, and iliotransverse anastomosis. On post-op day 2, patient suddenly collapsed. He had tachypnea, tachycardia, temperature rise, saturation fall, BP fall. Heart rate was raised to 160 per minute. Respiratory rate is 35 per minute. Temperature was like 102 degrees Fahrenheit. His saturation falls to 89% with 4 liter of O2. BP was 100 by 60. On examination, crubs were seen around the right side of the chest. ABG was taken, which showed metabolic acidosis with lactic acidosis. Total count was 2,530. CRP was raised to 221. Procalcitonin is increased to more than 10. Potassium level decreased to 2.6. Serum creatinine level raised from 1.3 to 2. He was stabilized with NIV, noradrenaline with dopamine and adrenaline infusion. Injection filgrastim was given. After giving filgrastim injection, his total count is raised to 15,000. Antibiotic hiked to imipenem and cilastatin. Albumin infusion, injection glucosamine and potassium correction were also being given. In this time, whether to reoperate the patient or redo the stomach or continue the conservative management, we have taken the decision to continue the conservative management. CT abdomen and thorax was done, which showed mild ascites with mesenteric fat stranding, bilateral mild pleural effusion. This is the CT film. On post-op day 3, cardiology consultation was sought in view of troponin level rise to 0.93, BNP rise to 1,430, persistent tachycardia. Echo was done, which showed no RWMA, mild tricuspid regurgitation, good LV function. IVC is mildly collapsing, advised hydration. On post-op day 4, suture removal was done in view of soakage of surgical site dressing. Seropurulent discharge was noted, which is drained under strict aseptic precaution. Daily dressing was given. On post-op day 6, noticed bile leak from surgical site, which was managed conservatively with vacuum therapy. Daily wound irrigation was done, which drained around 200 to 600 ml of bile per day. Patient improved symptomatically. He was started on RT feed. Bile refeeding was also given, incentive spirometry, and chest and limb physiotherapy was given. Patient improved symptomatically and he is being discharged. Patient is now on regular follow-up. Now 2.5 years post surgery, patient is living a normal life. There is no evidence of recurrence. Now, few notes about multi-visceral resection and sarcopenia. Locally advanced colon cancer, 5 to 25%, majority are appears in rectosigmoid. Large series has reported less than 0.4% incidence of pancreatico-duodenal involvement, range from inflammatory adhesions to fistula formation. Procedure become more challenging due to malnutrition. On around 60% of coloduodenal fistula, patients found to have anemia. Majority of patients have anemia and malnutrition. Fistula contaminate the foregut with colonic flora, which increases the bacterial overgrowth, which lead to malnutrition and anemia. Sarcopenia is a progressive and generalized loss of skeletal muscle mass and strength. Malignancy, in malignant condition, hypercatabolic state may occur due to tumor metabolism, systemic inflammation, and effect of chemotherapy. Angelsby et al. Demonstrated that core muscle size is independently predictive of mortality and complications following major surgery. Sarcopenia has also been shown to correlate with mortality, length of stay after colon resection, and surgical site infections. Investigations are exact localization of the fistula, plan the management. Barium enema is more accurate than barium meal. Multi-detector spiral CT scanners with multi-planar reconstructions are of paramount importance to identify these fistulous tract. Upper ureoscopy can also demonstrate the fistulous communication or direct inversion. Malignant Colo duodenal fistula, management based on proposed classification. There are three types of classification. Type 1, involvement of lateral duodenal wall with less than 50% of circumference. Primary closure is possible with or without sleeve duodenal resection or drainage procedure. In type 2, involvement is more than 50%. The circumference of duodenum or multiple fistula present at the site of involvement or away from papillae. Primary closure is not possible. Then we should go for segmental duodenal resection, duodenal closure, and gastrojejunectomy. In type 3, involvement more than half circumference of duodenum close to papillae. Primary closure is not possible. Then pancreatic or duodenectomy can be done. In coloduodenal fistula, in the setting of colon cancer, it is a rare event. Surgical resection should be tailored to the pattern and extent of involvement. Resection with negative margin can achieve long-term survival. Unexpected source of enteric leak may occur. This is, I'm concluding my topic here.
Hello. Yep. Am I audible?
Yeah, you're audible.
Thank you, Dr. Safina. That was excellent. Very well presented.
Thank you, sir.
I think since Dr. Safina is a junior doctor, so I think we should be kind to her, and we should let Dr. Rajkamal decide that which question she takes and which question he wants to take over. Is that okay, Dr. Pitambran? Yeah.
Yeah, okay.
Yeah. So if are there any questions in the chat box? No, I don't see any question in the chat box. So while we are waiting for questions, can I just start by asking two questions to the team? So I'm sure that it sounds like a very technically complex surgery, not just the surgical challenge, but also the perioperative challenge of managing this patient. I think regarding the surgical skills of Dr. Rajkamal and Dr. Pitambran, we don't have any doubts. So I'm sure they would have, not had any hesitance about the surgical expertise. But my question would be about two aspects. That how do you people deal with this case versus in your general GI surgery practice with sarcopenia? Like, how do you decide that? Do you have a particular score that when to say no to a patient, how to not operate on a patient? What is your cutoff score for sarcopenia? Question number one. Question number two is about the presence of liver disease. Apparently, your patient also had some liver disease because you said there was some ascites. So I would want to know more about the evaluation. Like, how did you evaluate the ascites? I mean, did you do a SAG? What was the explanation of the ascites? And about the presence of liver disease, again in this case, and also about your general practice in GI surgery. Because as a liver surgeon, in fact, this is one of my areas of interest where I'm working with Dr. Ramesh also, that we are working to see that how liver patients that we have had to do GI surgeries on, how those patients behave. So what is your experience? How do you evaluate for presence of liver disease? When do you say, even say for a lab coli, how do you decide? Do you go by the child score, MELD score? What do you decide that when not to operate a patient with liver disease and GI problems? Question number two is a small technical issue.
Abhishek, I think we'll take question one by one.
Okay, fine. Sorry. Yeah. Okay.
Yeah.
Got it.
So one thing, see, I think I would take up this question. Thing was that the patient actually didn't have a liver disease. The initial ultrasound picture was they have reported as chronic liver disease, but we have done an upper GI endoscopy, which didn't show any varices. The CT picture also was not suggestive of varices, and the patient is cachectic in poor with you can see the CT scan that there was ascites, abdominal wall edema, generalized albumin was 1.2. So there was two questions in my mind, and even this patient, many relatives have called me, and even some of the doctors' relatives. So as soon as the question was, when I described about the disease, the question most of them asked was that we will be doing a palliative management. Then see, okay, what is the palliation in this patient? Because patient is having a coloduodenal fistula with a bleeding and with recurrent anemia. There is nothing we can palliate. So that is why the decision was to take. So we have to do some sort of surgery. So to at least to palliate the bleeding or so that is the decision. So see, if we are going ahead with surgery, why can't we plan? See, and it was though locally advanced, whether there is no evidence of cirrhosis. So we thought that we could go ahead with the trial of curative resection, and we are not hoping to achieve that, but still we were trying to do something curative so that will give a better cure for the patient, rather than doing a palliative coloduodenal excision and doing a gastrojejunostomy. So if possible, that was the decision that we had taken, and hence we took the nutritionally build up the patient with the parenteral nutrition, because he was not able to take orally with this coloduodenal fistula. Whatever taken is patient was having loose motion. There is no option other than parenteral nutrition, and we can't give much fluid. Also, we have to make them maintain the intravascular volume. We have to maintain the renal function. All these things, issues were mine, and liver was not a problem in this patient because only the one ultrasound report was suggestive of chronic liver disease, and many
probably the ascites was just nutritional. So anyways,
Yeah,
forget about this case, but generally otherwise, because see, liver disease is becoming so rampant, alcoholic, obesity, NASH, etc. So it's like liver disease, you would obviously be encountering patients with liver disease, child A, child B in your GI surgery practice, with coming with colon cancer, Whipples, whatever, you know. So how do you decide that where do you cut off? Like even say a lab coli, how do you cut off that, okay, fine, this liver patient I'll operate, this liver patient I'll not operate? Like, do you have a score or just a learning thing? I mean, I'm just wondering.
No, the thing is that, see, we have liver disease, like many liver disease of lab coli is usually intraoperatively detected.
Right, yeah.
And if there is a patient is a non-cirrhosis with upper GI varices on endoscopy, we would like to defer, or we would like to avoid surgery as long as possible. Whether it is child A, B, or C, if there is varices on upper GI endoscopy, we would like to avoid.
Okay, got it.
Yeah,
okay.
Yeah, varices and no varices is one of the biggest criteria that will decide. It's the process of portal hypertension, and look at the platelet count also. If the platelet count is good and there is no varices, you could reasonably go ahead with the surgery depending upon the indication. And if the patient is not having much indication, then we may abstain from that. Then child A, B, C is an arbitrary criteria. So more than child's criteria, we look for this criteria.
No, I agree completely about that. Yeah. And regarding sarcopenia, do you have like, how do you decide this patient sarcopenia, this patient not sarcopenia, this patient middle sarcopenia? Like, I mean,
no, actually, we don't do much of that sarcopenia score and all these things. We don't do.
Just, I know it's most of the time it's just a clinical experience.
Yeah.
The second question, like just a short technical question, like in the end, you guys said that when the patient had some high output biliary fistula after the ileotransverse transverse closure, at that point there was some bile leak, and you said that you were giving the patient nasogastric feeds. So I was wondering how nasogastric feeds would be tolerating when the patient has a bile leak. I mean, what was the site of that fistula then?
No, I think Rajkamal will answer that question.
Yeah. Okay.
Yeah, sir. Actually, initially he was treated with a total parenteral nutrition, and he was applied the Vacuum therapy. And the fistula slowly the output reduced and gradually stopped.
No, so if I'm right, one of our slides showed in the end that we managed the fistula with nasogastric feeds, Ralstow feeds. So I was just wondering how that is possible.
Yeah, slowly when the output started coming, then we started him on Ralstow feeding with bile refeeding also, sir.
Okay. And so initially,
yeah, sir.
Got it. Thank you. Any other? I don't see any other questions. So, any Dr. Pitambran or any other people, I can let me just see who all are there online. So maybe Dr. Pitambran or someone can ask another question. Sorry, Dr. Pitambran cannot ask a question. Sorry.
The biggest challenge that I felt was not for the initial surgery. biggest challenge that I felt was in the second surgery.
The
Because the patient,
iliotransverse anastomosis.
yeah, the patient, not during surgery, post-operatively.
The
So
bile leak.
initially, we were operating a sick patient with a probably incurable malignancy. We were justified in doing all these things. See, whatever happens, the patient's relatives were very willing to accept all these things. But during surgery, he was absolutely tumor-free for first 1 year, and the iliotransverse anastomosis or ileostomy closure is a surgery that either we could have probably avoided risk, considering the risk of the patient. But everything, see, this patient had a collection in this during the second cycle of chemotherapy, which was detected, and it's ruptured spontaneously, and it was improved. So retrospectively, what I think was that there was a leak from the gastrojejunectomy site or even from the duodenal stem, which has collected, which has sealed spontaneously. This has happened during the initial 1 to 2 cycles of chemotherapy. So after day 2, the patient collapsed after the iliotransverse anastomosis. The patient is too sick to take into theater. We thought of taking him to theater because we thought that it will be an anastomotic leak at the iliotransverse site with a fecal fistula. So we planned for a redo ileostomy, but patient was on triple vasopressors, maintaining hardly the BP with a saturation also very low. So we were reluctant to take the patient because patient may die on table if you take the patients again. So that is the only reason that we managed him conservatively. And on the day 6, when the content of the wound was bile, we were really surprised because the leak is not from the iliotransverse side, but it's somewhere from the proximal. It was frank bile which is coming.
Right. Yeah.
So at that time only, we started with wound irrigation, vacuum therapy. We put Foley's into that with offset dressing, sucked all this collected fluid into a sterile container, and patient was on Ryle's tube. Ryle's tube output was not so much high, and the patient cannot be put on TPN for a long time. So we just gave it a trial. It's not like the Ryle's tube feeding is an option. Just gave a trial of feeding, and we started feeding at least some of the bile coming through the Ryle's tube. So which patient tolerated, and gradually the output was coming down. Gradually, due to the suction, the output was coming down, and the patient gradually improved.
Anyone else, Dr.
Yeah.
Sindhu Madam, Kuruvilla sir, Joshi sir, anyone else wants to ask any questions?
Yeah, I congratulate Pidam's unit for what I should say, the guts for taking up such a challenging case. It was wonderfully managed. In fact, many of us would think twice or thrice before opening up such a case. Anyway, it was well managed. Just 1 or 2 things. When the initial surgery, how long did you give parenteral nutrition? What was your index to say that the patient, now he's okay, you go ahead with surgery? Did you have any index, or was it the albumin value or the weight, or what was your criteria to say that he's okay to take up for surgery?
The patient was totally edematous in the initial when at presentation, and actually I was planning to take up the surgery, take the patient for surgery once the albumin is more than 3. This was the initial plan. But the problem was that during the course of the time, he had blood once, which with hemoglobin drop up to 4. And then again, another episode of hematemesis 2 days prior to surgery. So that is the time when we thought that it may be prudent to go in early rather than waiting till the albumin to become 3. And because moreover he was allergic to, see, if today we'll give Reliance albumin, he may tolerate. Tomorrow he may not tolerate to that albumin. Then we change the brand to Baxter, he may tolerate for 2 days. Then again lot of I have to thank the nephrologists and other team who were behind this, optimizing the patient for surgery. So because his renal function was borderline, intravascular volume was also less, and we cannot give parenteral nutrition without albumin also. So all these things were taken care of. So, and we took a call when after the second episode of hematemesis. So we thought that we'll go ahead now and took the patient 2 days after the hematemesis.
Great. Any more questions? Anyone else wants to ask any
I think
questions?
Dr. Joshi is.
Sorry. Another thing, during the second cycle of chemotherapy, you said you developed a collection.
Yeah.
Yeah. So, how did you continued with the chemotherapy, or usually that is a problem which we sometimes come across? Then how do you go ahead? You discontinued the chemotherapy, or how long you waited for it?
Actually, the patient was admitted for few days. The collection spontaneously ruptured through the main bone, and patient improved. Probably, I think maybe maximum 1 week of delay in chemotherapy was there. Otherwise, just after chemotherapy, he came to admission, and before the next chemotherapy, it was healed.
So it did not interfere with the healing process.
No, it is because it's spontaneously ruptured into the main wound, and we didn't do a percutaneous drainage, all these things. So it came out spontaneously. And
after the second case, when you said you had the bile leak, did you try to evaluate where it is from, or it settled spontaneously? So there's no collection, so you did not bother to evaluate further.
No, we didn't bother to evaluate where the collection is, because the patient was in the ICU on continuous suction. For that, we had to do an oral contrast to dye study. So we have to shift the patient to CT scan. So we didn't do that. Once the patient is improving,
fair enough.
There is, I think Dr. Karthik has raised his hand. So Dr. Karthik wants to ask a question.
Yeah. So, sir, thank you for the excellent case and very challenging case, very well managed. I just wanted to ask you something, sir, like this nutrition thing itself. Suppose you're planning a surgery for such a patient, and suppose you are planning a case which needs a resection and anastomosis. Suppose it's a large tumor from the small intestine. You can't just put a stoma and come out. So in that case, what will be your ideal, cutoff point where you will say, okay, at this cutoff point of albumin or this cutoff point, I'll take the patient for surgery and do an anastomosis and come out. Do you take the absolute value of albumin, or you see the patient in general? How do you decide?
Rajkamal, want to take up that question?
Sir, not only the albumin level decides, like even the overall performance and well-being of the patient, also the intraop status of the bowel. I think it has to be a collective decision. Yeah.
Yeah, I agree. I think I agree. Unless Dr. Karthik has something to add, I think no one really can't stick to particular scores here. I think it's always I think experience always has something to teach. I mean, so that's why that's the importance of a team. Like, I mean, especially your critical care team. Like, your critical care teams should absolutely be on board. They should understand, because otherwise, a lot of times we see that we hear from all people that there is no support, or sometimes there might be even a conflict of opinion, etc. So I think that teamwork here is very important. We learn from each other's experience. So I don't know if someone wants to add, but no, even I don't follow any particular written score in my practice. It's always more of a subjective and a team decision.
Hello.
Anyone wants to come in on this? Someone wants, I think Dr. Karthik again wants to come in, so maybe someone else can come in also.
Hello, Sindhu here.
Sindhu madam, yeah. Sindhu madam, please.
Actually, what is the message that take-home message you want to give it to the community? I mean, the group from this case, or you can't generalize these things.
You want me to answer this question?
You are bound to answer today.
Yeah. See, I am bound to answer. No, only thing is that sometimes as we are stuck up in, see, the thing is that in this case, it was a tough decision. And I can present this case because it gone well. It may not happen every time. In this patient, we have taken this decision out of, what to say, no way, out of, we have no way, no other way out. Because with a gastric coloduodenal fistula, with a patient having recurrent bleeding, we have to do something to at least reduce the bleeding. That is the only reason that we had gone ahead with the resection of this case. Otherwise, it will be difficult. And whatever it is, the message is, if you want to go for a resection, optimize the patient with a nutritional buildup rather than going in immediately. And you have to think of all the possibilities while the patient develop a fistula postoperatively. That is the one thing that I learned from this patient, not the first surgery that taught me. Actually, I have to thank Raj Kamal for this. Without him, I wouldn't have got this patient back, because he has got that wonderful experience from HR's unit, how to do the suction, how to do that upside dressing, all these things. See, he was doing that thing very well. And that is the only reason why. And really surprising was bilious leak from a iliotransverse anastomotic site. Not anastomotic site, in a patient with iliotransverse anastomosis. As in, Sindhu madam, I will just ask you, I want to ask you something. What message did you get in this patient?
I think I would like to summarize it as teamwork. Teamwork plus what do you say, damage control, stage procedures, and teamwork. Yeah. Good work by them, Pidambran and the team.
Thank you.
Ahmed, Ismail raised hand. Someone has raised their hand. Please go ahead and ask your question.
Yes, my dear. Thanks for allowing me to join this valuable meeting. Actually, I was late to attend the presentation.
Dr. Ahmed, can you introduce yourself? Sorry.
Yes, I am Dr. Ahmed Ismail, surgical oncologist from Egypt. About this case, I want to ask if there was any chance to treat the patient in a multidisciplinary team, and I want to know if there was any chance to deal with hematemesis endoscopically, either by upper or lower endoscope, to manage the bleeding, and if there was any chance to palliate this bleeding or stop bleeding with a less invasive procedure than surgery, then to build up the energy stores for this patient and deal with as T4 colorectal cancer before intervening with the surgery, because surgery for this patient is very stressful and very injurious procedure as such condition. Was there any chance for these solutions before going ahead for surgery?
Yeah, so Dr. Pitambran, what Dr. Ahmed is asking is that that is there any way that you could have managed the bleeding endoscopically, one, and could you have done a lesser surgery to manage just manage the bleeding and not do such a massive resection? So before Dr. Pitambran answers that question, can I ask Dr. Ahmed back that what surgery would you suggest? I mean, out of curiosity, like a minimum surgery.
He was not suggesting a lesser surgery. He was telling some lesser procedure before surgery.
Okay, I thought that he was saying that instead of doing a palliative resection, just maybe some local control of surgery. So is that what you meant, Dr. Ismail?
Yes.
Did you meant a lesser procedure means a lesser operation, or what do you mean by a lesser?
Endoscopic angiographic dealing with the bleeding, something like this, to have decision from other specialties, from interventional radiology, from the oncologist, to be less injurious before going ahead massive surgery for this patient.
Okay, so he's talking about non-surgical interventions. Did you try
surgical intervention before a surgical? So usually this coloduodenal fistula bleeding is not from a single vessel, because this is an ulcerated area. That bleeding can occur is diffuse ooze, which cannot be controlled by usually by any intervention radiologic methods. Other option is that palliative hemostatic radiotherapy. And once you give a palliative hemostatic, this is another option, but it also can be tried sometimes, but it also fails most of the time.
No, I agree. I agree that endoscopy is only a stopgap measure. It always rebleeds. So you just have to, you have to find a permanent solution to the bleeding. That's always surgical only. Yeah. Any other questions? Anyone else wants to ask any questions? So if there are no further questions, Dr. Pitambran, I think we can all enjoy our Saturday now. So I'll hand over back to you. Thank you very much, Dr. Pitambran. Good night.
Usually Shabir Ali will ask something. I'm waiting for Shabir Ali to ask something.
No, Pitambran, actually, I didn't hear the first part. I didn't get what case it is. That's why I'm staying silent.
Okay. Irula, sir.
Hello, Vidambaran. Hearing this talk, the presentation, I felt that you are lucky. See,
yeah, I am really lucky.
You are forced to operate on somebody, but you are lucky that many things fell into line and saved the patient.
Yeah.
You cannot expect same result in another case of similar nature.
Obviously, sir. Actually, we have taken up this patient with the explanation that mostly.
I agree. You did not expect such problems happening in between also, because try to improve his nutritional status by giving support pre-operatively. So you expected that these things will maybe delayed or slow, but you would not land up in such problems. But it was lucky that you could get out of those problems. One thing I was just wondering, you said total parenteral nutrition. What did you mean TPN in this patient? Did you continue giving orally plus albumin supplementation, blood transfusion, etc., or really meant complete total parenteral nutrition?
Actually, he was given complete total parenteral nutrition along with some liquids as tolerated, especially mainly some protein feeds. But most of the time, whenever he takes, there was diarrhea. And it may precipitate bleeding also. That is what happened. So, but we didn't restrict anything, like we didn't kept NPO for him. And moreover, we had given amino acids along with that. Yes, sir.
I didn't really get where the anastomotic leak you mentioned was from. Initially, you did a gastrogenostomy.
Yeah. So we couldn't demonstrate the anastomotic leak at any point of time.
No.
Yeah.
Was it an end ileostomy and colon closure initially, and then
end ileostomy and distal colon closed.
So you could have done a anastomosis with a diversion if that was the plan. Why did you do that?
Sir, because the initial surgery, I want to minimize as much things as possible.
Okay, right. Yeah, leak was from the ileocolic anastomosis or from duodenum?
Leak was probably from the duodenum or the gastrojejunostomy.
It could have been probably from duodenum, and that is the only reason why it stopped. Because if it was a ileotoxic leak, it would not probably stop that way.
Obviously, sir. It is from the upper GI tract itself, because 500 to 600 ml of bile was coming.
Yes. So duodenum, because the GI tract was patent, slowly it stopped. It happens naturally like that. But if the ileotransverse anastomosis leak, this that will result in stricture, and the healing would not take place. That is the usual thing.
Sir. Yes, because
the chemotherapy, I also have had a couple of problems referred from elsewhere after developing leak. where during second course of the chemotherapy, third course of the chemotherapy, they found leak. But that I believe that this leak could have happened, a small leak could have happened even in the initial phase that remained as a concealed leak. But chemotherapy suppressed immunity, started developing an abscess there and grew in size and finally burst into the through skin outside. Since it happens over a period of time, it didn't go into the general peritoneal cavity. But the leak happened probably in the beginning itself.
That is what I was also thinking.
Chemotherapy may not induce a leak.
Yeah, that is what I was also thinking, sir. There was, because the nutrition status of the patient was poor initially.
Whatever be the reason, whatever be the reason, it would have happened initially.
Yeah, initially there would have been leak from a duodenal or from the gastrogenostomy side, which had healed spontaneously, which presented the same leak presented again in the second cycle of chemotherapy. After that, probably while doing the laparotomy and ileotransverse dissection, this would have opened up again.
That would have been the more possible reason.
That is the possible reason that I was thinking, sir.
Yes, that's the reason why I was wondering whether they could have done a ileocolic anastomosis and a diversion. Then you don't need to go there. Diversion in the sense loop ileostomy.
Okay, in the initial surgery itself.
Yeah.
Yeah, that is
anyway,
that is the reason I told you now, because as we want to make the things as minimal as possible to do anastomosis.
Okay. All depends on surgeon's decision on table. Anybody can make any comment, but finally you have to do it. Then it is your decision is best. Thank you. Anyway, patient is alive and well. That is the more important thing, and it is free of disease. Free of disease is also another positive thing about it. We can hope to see him in the coming years as well. All the best to you.
Thank you, sir.
Yeah. So anything else? So can we finish the session now?
Yeah, we can conclude the session. I think we can go back to our president.
So thank you very much. Yeah.
So thank you, Dr. Abhishek, for moderating the session in a wonderful way. It was, as all of you would agree, it was a very, very challenging case which Dr. Pitambaran's unit has taken up, and it was presented well. And since there was no senior trainee, Pitambaran had to bear the brunt of all questions and answer all those questions. Anyway, I think there are a lot of learning points and that we gained from this discussion that we had. And of course, luck and fate also plays a big role in the outcome of such patients. And fortunately, Pitambaran could manage it successfully. So thank you all. Thank you once again. Let's hope to join for another session next month. Thank you. Good night.
Good night. Good night, everyone.
Good night. Thank you.
Thank you. Thank you, sir. Thank you.